Thank you. It's an honor to be part of this panel, and I think it was set up great by the previous two speakers. I'm going to be talking about designing systems to support patients as safeguards, and you'll understand what I mean by that as we go along here. So first I want to talk about the problem of medical error, which shouldn't be a surprise given our first two speakers. But I think it helps to think about this in context. So it's been given that it's the third leading cause of death in the United States. Pause for a minute there to think about that. One study has showed that there are 440,000 deaths a year in the US alone due to preventable medical error. What does that mean? I think it helps if you have a visual. So that's really like 7 airplanes crashing a day. Just from preventable medical errors just in the US. And if you look at the kind of harm that's done, it's more like a whole fleet of airplanes. So this is a serious problem. But I think it also helps to tell a story, to really give a personal context. So let's take the case of John. So John has been sick for a while. He's been in and out of various ERs and doctor's office and having strange symptoms, but he's getting worse. So he goes to the urgent care clinic and encounters a physician who's doing some detailed documentation of where he's been, really trying to uncover this mystery. And she finds out he's been in Vermont. She looks at his symptoms like, I really suspect that you have Lyme disease. But she follows up, does an EKG, and notices some substantial problems here. He has atrial fibrillation and a second-degree AV block. So she says, we can't deal with that here. I want to send you to the emergency room right away, and I'll send all this information with you. So John goes to the emergency room, where they do pay close attention to him. But he and his wife request that they do a blood test for Lyme disease, given what the previous clinician said. That's denied. They say they can't follow up on something complicated like a Lyme disease, so they're not even going to investigate that here. Instead, a nurse comes up and presents him with a pill in a cup and says, here, take this. His wife chimes in and says, wait a second, what is this pill? And the nurse says, oh, this is metoprolol. She says, well, what is that and why is he taking it? The nurse says it's a beta blocker. The wife says, wait a second, his heart rate is very low. It was down in the 30s and 40s. Is a beta blocker really the right thing to do? The nurse gets all defensive and is like, no, you have to take this right now because he's in danger of having a stroke. So the problem is that this drug is actually exactly contraindicated in this case. It's never supposed to be given to somebody with such a low heart rate or somebody with a second-degree AV block. Unfortunately, John then crashes after this and he does survive, but spends the next week in the cardiac intensive care unit. Now, this example means a lot to me because it's actually my husband who was in this situation, and I was the wife talking about that. So this says that even people who are very well educated can fall prey to these kinds of problems because it's a very complex system. There's a lot of information being passed around and a lot of players involved. So what is the problem here? Think about it. Who would you blame for this? Unfortunately, I think a lot of us, including the media, take this bad apple approach of, oh, it was the nurse or the doctor who ordered this, and that is their fault. They should be punished, and therefore, that's the solution. And that's often what the media portrays for these prominent examples of medical error. But hopefully, from what we've heard before, you all realize that that's not really what's going on here. It's really a system-wide problem, a socio-technical system here at play. I really like to look at this figure that was adapted from James Reason. That's really taking a systems approach. Healthcare is very, very complicated. There are a lot of hazards at play. And his idea is that we need to come up with different kinds of blocks to try and block this air from propagating out and actually causing harm. None of those blocks are going to be perfect. They're more like pieces of Swiss cheese. That's why he calls it the Swiss cheese model. But if we have enough of them, and appropriately enough, they can block that air, that possible air, from actually happening and causing harm. So there's been a lot of great work in this space. We've known about the problem of medical error for a long time, things like surgical checklists, things like medication barcodes. But I argue the thing that's been the most neglected is looking at patients and caregivers themselves as possible safeguards. And that's really the core of my project and where that's coming from. So I have funding from the Agency for Healthcare Research and Quality, AHRQ, that's looking at exactly this problem and approach. Our aims are to look at identifying the information that would help patients and caregivers increase their situation awareness of what's going on, what should be happening, and why it's happening. Also helping them to manage that information and keeping track of what's happening to them so that they can alert the care team of particular problems. And then developing strategies to increase the communication, to have effective communication when they identify potential problems and raise a flag. So the kinds of approach that we're using is very much a human-centered approach that the others have talked about as well. We've been doing observations and interviews. We've been doing prototyping and technology probes, and we've been doing participatory design, really designing with all of the stakeholders, particularly patients and caregivers. So what have we found so far? On the understanding side, we've already been doing some of this work. We've done over 118 hours of observations, focusing on following clinicians in a variety of different settings and specializations. But we've also done a variety of interviews and observations from the patient and caregiver side as well. And we've done this from both a pediatric and an adult hospital to try to get a maximum variant sampling of the kinds of situations that go on. So what have we found? We found that the entire hospital environment is an extremely poor environment for information sources for patients and their families. We found that the kinds of information that they get is largely verbal, despite the fact that they are possibly cognitively impaired from what's going on to them, that there's new vocabulary, yet everything is conveyed to them verbally. These information interactions are unscheduled. Patients and their caregivers have no idea when somebody's going to come by, so that they can be prepared for that and make sure they have the support system there to help address that issue. And lots of unexpected information comes up that they don't know how to deal with. They have difficulty tracking information. They even have difficulty providing information because they don't understand what they should and shouldn't be providing. So this leads to what we've seen is a large amount of unsupported patient and caregiver information work. An example of this is a quote from one of our participants. Most of it I scrawled on the back of some pamphlets that come out of a box of dressings because I didn't have any paper. They did have a whiteboard in my room, so I could keep track of some of it there, but some of it was embarrassing, and I didn't want it available to read by anyone who walked into the room. Lots of hospitals have these whiteboards available, but I don't think they think about all of these consequences in the patient's perspective there. Another quote, this was from a parent. We spent a lot of time sitting around and waiting for the doctors. Then we would go to the bathroom or go get food and come back, and they would have been there without speaking to any of us. We would have to wait a whole nother day to ask our questions or share information or observations. So a lot of frustrations from the caregiver side as well. Excuse me. So our approach has really been one of co-design, really involving patients and caregivers throughout the entire process. So we've been doing design sessions, participatory design sessions with patients and caregivers. The reason we do this is because this approach is a known way to help share control, to share expertise. Both the patients and caregivers have expertise, as well as the designers, but we can work together to motivate change and facilitate this exchange of expertise. I also like to think of this in another way. We think about naturally asking people about what their experience is. So we get from them what they say they do. We get from observations understanding what they actually do. But we get yet another take on them when we ask them to make things. And so our approach has really been that we need all three of those prongs to really deeply understand a patient and caregiver perspective in this situation. So they've come up with a number of different designs here. One was interesting, looking at a sharing out design. This was looking at the burden of sharing the same information over and over again. If you think about it, anytime you've been to a doctor's office, how often are you asked to repeat that information? Well, that can be annoying and frustrating, but they talked about it from an error perspective because they're worried they could forget one time. They get sick of retelling it. They're not sure, did I mention it this time or did I not? And is this the right person to say that to? So they created designs to a personalized version to share out the important, that important kind of information to the whole care team, as well as to personalize it. They also looked at ways to be prepared. So expressing this frustration of being trapped in the hospital room, the caregiver's trapped, waiting for the doctors to come and not having any idea when that's going to happen. So they created something as an analogy to an app called One Bus Away. It's a mobile app that people have used to keep track of when their bus is coming. It shows information like when, what bus it is and when the expected arrival time is. Note that sometimes it's later than expected and those kinds of things. So it's a nice analogy here too. The patients drew their own One Doc Away app to let them know when the doctors were expected to come, knowing that whether they were 1 or 2 patients away, whether they were behind schedule, allowed them the freedom to leave the room to take care of other kinds of things and be prepared and ready for when that doc came. They also wanted to know who is who. As we heard, there's so many people coming in and out of the hospital room, and they have no idea who these people are, what their role is, or why they're even there. So one set of patients created an identitron to show people's faces and their roles and the kind of background that they have to try and enable kinds of communication. So we've taken the participatory design approach and now gone another step to create more of a low fidelity approach and connecting with patients and caregivers on what kinds of features that they would want to use. And here we take an approach of really designing with them, of giving them some different examples of kinds of features and letting them pick from those and design their own app and see what kinds of things that they would choose. So we had things to choose from for things like expressing doctors' feelings about my health. This turned out to be a major failure. Although they wanted to know that, they did not want to ever see this. But that helped us understand their needs and the kinds of level of information they wanted. Even though they designed to want to know about that and expressed a design for that, seeing it was an entirely different experience. We even looked at different kinds of ways that it could support patient-doctor communication through the technology. And now we're also working on technical probes. We're now at the stage where we're developing mid-fidelity prototypes to try and build out some of these design ideas and actually taking them into the patient's room in the hospital setting and seeing their reactions to this. What we've done is created 3 different types of designs. This one is more of what we call a categorical view, which is a little more similar to the typical organized by problem type list that are in patient portals and electronic health records. We also look at issues around a timeline view of seeing what's supposed to happen when to help people be prepared for that. See when things like a medication order has been entered. So for the example of John, could we have seen that this medication was ordered and we could have looked at the kinds of contraindications for that drug and actually been prepared for the interaction when the nurse came into that room. We also looked at a different kind of an approach, and that's looking at a goal-oriented approach. We heard from patients that they often have particular goals that they want to meet. One of the most common ones was to get out of here, get discharged. So how does that look from their perspective, and how does that look from the clinician's perspective to connect up? So we've done a variety of these kinds of mock-ups, and we're doing studies with those now. So far we've really learned that patients do need lots of information support. Although there are tools like MyChart Bedside and Epic and then Cerner's systems, we've really found that we need to move beyond these types of technologies. Patients really need to understand the plan of care, the what and the why of what's happening to them. They need a schedule of when these things are going to happen so they can be adequately prepared, the when. They need some more visibility of the who is taking care of them, as well as the communication support to raise flags and connect, so the how that's going to work. So I want to thank my team and participants in our study.